This meeting is actually, we're featuring Susan Hamilton. She's a Master's of Science. She's a research specialist, Women's Mental Health and Infants Program, University of Michigan Department of Psychiatry. And we were just discussing when I was getting to know her what she does, and that she actually works with the nursing students, helping them with their research projects. One of our members, Roxanne Chan, actually went through her program and did research in yoga for the chronic COPD. Yeah, COPD, yes, yeah, and did her dissertation. So we featured her program last year. So anyway, I thank Susan for filling in tonight and being available to give us this wonderful presentation. I'm really new to yoga myself and new to meditation. I'm a registered nurse from all the classic things, and I've been doing a lot on nutrition, but not a lot on the yoga and on the breathing. I've been learning that just the last few years, and so I'm excited to hear what you have to say.
Great, thank you. Thank you so much. So I'm Susan Hamilton. Thank you so much for that wonderful introduction. Since we do have a small, speak up? Okay. Since we do have a small group here today, who here has heard of yoga and or mindfulness? So I am going to be presenting on a paper that we wrote a couple of years ago and was accepted for publication in the Complementary Therapies and Clinical Practice Journal. The co-authors were Kate Rosenblum, who works here actually in the Center for Human Growth and Development as well as the Department of Psychiatry. Ellen McGinnis, who's a PhD candidate at the University of Michigan, and Zara Hadi, who is currently working as a social worker in Texas right now. Our M-Yoga instructors were Barbara Brooke and Harvey and Marlene McGrath, both from Inward Bound Yoga in Ann Arbor. Barb and Marlene are both social workers as well as yoga instructors with a lot of experience doing prenatal yoga and postnatal yoga especially. Depression and pregnancy. So there are 3 times in a woman's life when she is considered at higher risk for developing disorders. Puberty, the perinatal period, which is defined as pregnancy and then the first year postpartum and then perimenopause. These times are fraught with hormonal changes and role transitions, emotional upheaval, lots of physical changes, natural increase in stress. Unfortunately, even though puberty and perimenopause are identified, or it can be seen as times when you would expect to have difficulties, pregnancy is a time when women are expected to glow and thrive. And since some of the serious mood changes that may happen, they go unnoticed by patients and untreated by doctors. Symptoms are similar to depression at any other time in a woman's life. Depressed irritable mood, feelings of guilt, worthlessness, inability to experience pleasure, trouble concentrating, appetite and weight changes, decreased energy and fatigue, sleep disturbances. A lot of these sound like early pregnancy, right? Yeah. So in women who have experienced an episode of depression prior to becoming pregnant, they are considered at higher risk and may often confuse those feelings with I'm pregnant, so that's why I can't sleep. That's why I'm having a hard time eating. That's why I can't concentrate. And then it goes on and starts to develop into more of a problem. In a woman who has not experienced depression in the past, she may just be like, well, I am pregnant, and that's what's going on here. Risk factors for developing depression during pregnancy. Lots of stuff. If you've had problems with infertility or past pregnancy loss, this can be a very confusing one for women who struggle with infertility for many years maybe, and you're finally pregnant. Why am I depressed? And then there's this, I'll get into this in a minute, but just powerful stigma surrounding mood disorders during pregnancy. So a lot of women who are suffering aren't going to talk to their doctors about it, aren't going to tell partners, their friends, thinking that they're the only ones. Other risk factors may include a lack of social support, low socioeconomic status, chronic pain. Often it's not safe to take NSAIDs or ibuprofen during pregnancy, and pain medication like narcotics are difficult too. So if you already have a chronic pain problem, it gets worse, and that contributes to depression too. A history of sexual assault or trauma, current or past substance abuse dependence, that includes cigarette smoking, and stopping antidepressant use due to pregnancy. 50% of women taking antidepressants stop when they find out that they're pregnant. So 10 to 16% of pregnant postpartum women are meeting 5 of those criteria, which is really good. That's a lot of women. One study, Gaines et al. In 2005 found that 86% of pregnant women who screened positive for depression in an OB clinic did not receive any form of treatment. Often that means that they were in a survey that said that they were at risk for developing depression, or talked about it with their doctors. Doctors will make referrals, but a lot of times women will not follow up on them. As I mentioned, up to 50% of women who are taking antidepressants stop taking them when they become pregnant. And a lot of women prefer psychosocial treatment, but it's really hard to start therapy or other alternative. Right, okay, so when you're pregnant, I have a case that I'm going to introduce in a moment. Transportation issues, childcare issues, lack of insurance. Maybe you live in a small town and you don't want anybody to know you're going to therapy. All of the usual problems around seeking therapy for a mood disorder or any other mental health problems are magnified when you're pregnant. Because you're not supposed to be depressed. You're supposed to be happy and glowing and thriving. And then even if you are able to get into treatment, it's very hard to stay in treatment for all the reasons I just described. So here we have some of the consequences of untreated depression. Mothers are more likely to engage in unhealthy behaviors, such as smoking or illicit substance or alcohol use or nutrition. It's harder for them to make their prenatal appointments. More pain and discomfort during pregnancy. There are poor pregnancy and birth outcomes, like poor birth weight, poor growth through gestational age, lower APGAR scores, more interventions happen, like C-sections. Their babies are crying more and having some disturbances. And then obviously risk of postpartum depression. I feel like postpartum depression gets all of the need. Everybody knows what postpartum depression is, but there isn't a lot of awareness about pregnancy and depression. It's really important. Case vignette. Ashley was referred to our high-risk prenatal team by her OB in her first trimester, about 6 weeks. She's 28. She doesn't have a partner. She has 3 of her children, age 10, 4, and 2. So she was 18 when she had her first. And she has a history of depression. When she calls intake at 13 weeks, she reports that this pregnancy is likely the result of a sexual assault, and she's decided to keep the baby. She describes severe depressive symptoms, including insomnia, low appetite, feelings of worthlessness, and thoughts of harming herself. This is a pretty severe case. In addition, she's having incapacitating panic attacks and constant worries about the safety of her children when she's not with them. She schedules an appointment with her prenatal team, but no-shows twice because of missing it. I'm not sure, how many of you are familiar with the University of Michigan prenatal team? Okay. So it's a special team of doctors and psychiatrists and social workers that are devoted specifically to the care of pregnant women and women in the first year postpartum. So if you call the depression center and say that you're pregnant, you get transferred immediately to this team. There's a lot of, it's interesting because I'm a therapist myself in downtown Ann Arbor, and it's interesting to me that there are a lot of clinicians who are afraid of pregnant women, who are unsure about how to treat them, And it's difficult to find somebody who's both knowledgeable about pregnancy and mood disorders as well as comfortable treating somebody who's in a very high risk part of their life. Is that something that resonates with you guys? When Ashley is finally seen in clinic, she is well into her second trimester and brings her two youngest children with her. She tells the clinician that she was recently fired from her job as a cashier because she missed too many days of work and is in the process of applying for Medicaid, so she lost her health insurance. She's never been in therapy before and is reluctant to take antidepressants. During the intake session, Ashley's affect is flat, her mood is depressed. She has a hard time explaining her history because of the many interruptions by her 2-year-old son. Despite her symptoms and a difficult first encounter, she seems to engage with the clinician and agrees to schedule a second appointment. This is obviously a case vignette that's drawn together from many women that we see in clinics, just many very specific. But you can already see, this is her first appointment. It was so difficult for her to even get to this place. And yet, she's already coming up against barriers. So, pharmacological treatment. The American College of Obstetrics and Gynecologists recommend that women should consider psychotherapy prior to medication. But if she's severely or moderately depressed or has suicidal ideation, they recommend that she stay on antidepressant. However, 68% who discontinue medication during pregnancy experience a relapse, compared to 26% of women who continue their medication. That's a really staggering figure. And although research studies indicate that no major malformations are associated with antidepressant use during pregnancy, the jury's still out on a lot of this. There's insufficient evidence. We can't say, take this antidepressant and everything will be perfectly fine. We don't know that. And because it's such a high-risk group for research, doing a clinical trial that's randomized is impossible. You can't have women who are pregnant and suffering with mood disorders and not treat them. It affects more than just the woman herself, it affects her child and her family. So, non-pharmacological treatment, a couple different kinds of psychotherapy that are helpful. Interpersonal therapy, useful for interpersonal conflicts, problem transitions, unresolved grief. Cognitive behavioral therapy, which targets negative thinking and behaviors that indicate depression. And alternative treatments, like omega-3 fatty acids, fish oil, bright light therapy, St. John's wort, acupuncture, and then mind-body modalities, like what we're going to be talking about in a minute. So as we were saying, that few women suffering from perinatal mental illness actually receive treatment. And there's a powerful social stigma around perinatal depression. So if you've got these symptoms, a lot of women think that they're the only ones suffering, and they will do so in silence, in the name of, I want to take care of my baby. Not realizing that untreated depression also has an impact on your pregnancy and your health. And a lot of women wouldn't know where to go necessarily if they're hesitant to seek help even if they knew where to go and it was easy and they had transportation and health insurance and all those things make it easy for women to seek help. So, when traditional treatments are feared or rejected, more evidence that complementary and alternative medicine is going to be possibly more acceptable to the average woman. And a lot of people may never have considered complementary and alternative medicine strategies before becoming pregnant. So it's much like when you're pregnant, there are warning labels on all medications, right? You can't take cold medication. So perhaps a woman would be more likely to explore nasal irrigation, neti pot, for example, which maybe she wouldn't have wanted to do something like that when she wasn't pregnant. So it sort of opens the door a bit. And in that way, it's a good thing in that we can perhaps complementary alternative medicine strategies may help women who are not pregnant as well, but this is an introduction. One of the things I love about working with pregnant women is that this is an incredible time of transition and role changes and if there is like for example, if somebody she stops smoking, it's a good time for healthy behaviors to highlight and make her ancient practice that involves meditative poses, meditative focus combined with physical poses. Yoga has been shown to have many positive health effects, reducing stress, reducing chronic pain, decreasing the incidence of depression and anxieties. Yoga has been studied and studied and studied a lot over the last 20 or 30 years. In India and China, I believe, there were studies with thousands of women, all healthy, pregnant women. I mean, there are obviously lots of studies on people who are not pregnant and yoga, but most of the research that's been done on yoga for pregnant women is with women who are healthy, who have no other problems. So what we know is that it does work in those populations of women, but what we're trying to figure out, does it generalize to women who are struggling with psychiatric disorders as well? What is mindfulness? Who here has done mindfulness meditation? Alrighty, okay. So, mindfulness is one of those concepts that is very simple but very difficult to explain, right? So, it's being in the moment right now with no judgment. Moment-to-moment observation of the mind-body process. Being fully aware of whatever is happening. You're not a judge, you're a scientist. You're curious instead of judgmental. I love this. It's from Eckhart Tolle. So in the future, we have too much future, not enough presence, unease, anxiety, tension, stress, worry, all forms of fear. And then too much past, not enough presence, guilt, grievances, sadness, bitterness. And we are in the middle. Yeah. So mindfulness is historically rooted in ancient Buddhist practices, but it's become an important part of many spiritual traditions, Christianity, Judaism. It's expanded far beyond its spiritual roots. Mindfulness is all over the place now, and I love this cartoon for that reason. So here we have a geek meditation session. In your mind's eye browser, clear your cache. Now delete your history. Now navigate to a blank web page. Doctors are prescribing training in mindfulness to help with a range of psychological conditions. I'm not going to get too much into this here, but John Kabat-Zinn, who's sort of like, I mean, obviously mindfulness is a centuries-old practice, but Kabat-Zinn kind of brought it to the U.S. There's a great story about combining yoga with mindfulness. I guess that John Kabat-Zinn was teaching a meditation class at the same time a colleague of his was teaching a yoga class, and they thought it was interesting that different people went to the two classes, and so together the two of them decided to sort of join the two because they felt that each of them could be complementary, which gave birth to mindfulness-based stress reduction, MBSR, which is an 8-week course. You can take all over the world that is an introduction to mindfulness and does a little bit of yoga as a complement. And that has been modified for all kinds of groups. So there's mindfulness-based stress reduction for teens, MBSR for people who have struggled with their depression, for cancer patients. It's one of those universal, you can apply to just about any population. Has anyone taken the mindfulness course? Okay. Did you take Libby Robinson? Yeah, I love her. So, think of your mind as the surface of a lake or an ocean. There are always waves in the water. Sometimes they are big, sometimes they are small, sometimes they are almost imperceptible. The water's waves are churned up by winds which come and go and vary in direction and intensity, just as the winds of stress and change in our lives, which stir the waves in our minds. Mindfulness beats stress every time. This is just a list of some of the research that's been done on people completed mindfulness screening. Significant decreases in anxiety and depression, improved concentration, lasting decreases in a variety of stress-related physical symptoms like chronic pain. I mentioned decreased symptoms secondary to cancer, improved immune system functioning. That's a pretty wide range. So why do we put mindfulness and yoga together? Mindfulness and yoga are natural partners during times of stress and difficulty, during pregnancy especially. Lots of aches and pains and normal changes and emotional changes during pregnancy. So here's some of the research that's been done on yoga, mindfulness, and pregnancy. And you notice all these are very recent. It's 2012 and 2008. So in Healthy Women Again, we found that prenatal yoga by itself significantly reduces the perception of pain during labor, and significantly reduces the duration of labor, lower hypertension, babies are growing bigger, labors or pregnancies are lasting longer, healthier babies resulting. And then a prenatal mindfulness-based intervention significantly reduce anxiety and what they're calling negative emotions. So together, put them together, and you have sort of double the effects. A lot of women seeking treatment for depression are interested in prenatal yoga, but not a lot of research has examined it as a treatment. Our study was the first one to look at prenatal mindfulness yoga in actively depressed women, which just kind of blows my mind, really, considering how powerful it is. Beto, in 2009, she found that yoga and mindfulness-based stress reduction, or BSR, significantly decreased emotional stress and physical pain in pregnant women with a history of depression, but she didn't look at women with current psychopathology. So we don't know if it could have been generalized to women with psychiatric illness. And I mentioned this is the first attempt to close this gap in the literature. We're exploring the efficacy of M-yoga in reducing symptoms of depression and anxiety among pregnant women with current and lifetime diagnoses. So we're looking at, our hypotheses are that mindfulness yoga will help, basically. It's going to reduce depression, it's going to increase attachment to the baby, it will increase empowerment towards the pregnancy, reduce social isolation, all good stuff. So this is back in 2009, 2010. Pregnant women were recruited through university-based clinics and flyers. Free participation in a 10-week prenatal M-yoga, mindfulness yoga, class to improve well-being and decrease stress. In my 10 years managing research studies, this was the easiest recruitment I have ever done, ever. I am still getting calls about this study that we ended recruitment for 4 years ago. Yeah. A lot of women are very excited about it. And we posted flyers in OB clinics across the county through the yoga system. And people just left the flyers up. So maybe thinking it was an ongoing program. But yeah, I literally got a call like 2 weeks ago about this. Yeah. And so I just referred them to Barb and Marlene, who teach in the community. It's just wonderful. So the inclusion criteria for the pilot study was that you had to be a first-time mother, speak English so you could fill out the forms and complete the clinical interviews, understand the yoga instructors. You had to score above 9 on the EPDS depression screen. EPDS, the Edinburgh Postpartum Depression Screening Scale, is a 10-item scale that is becoming more widely used in OB clinics. Actually, like even there's like different languages. A lot of different language versions have been developed for the EPDS, sort of like the gold standard of assessing for depression. And unlike other depression inventories, some of the questions that specifically relate to pregnancy are taken out. Like like, are you having trouble sleeping? Yeah. I'm 8 months pregnant. I have to get to pee every 20 minutes. So that's taken out of this particular one. And 9 is considered at risk for developing depression. Not taking medications for mental health conditions. So all of the women in our group were trying to target women who were at risk for depression or currently depressed, but not comfortable taking antidepressants or anti-anxiety medications, or who had stopped. And you had to be less than 26 weeks gestation because it was a 10-week course. I think the first class we had went over the Christmas holiday, and so, you know, we had to make sure that you did deliver before the end of the class. And you were excluded if you had active substance abuse, psychosis, or suicidality. So we're looking for women who are at risk, but not seriously at risk. So we screened 49 women over a 4-week period. It was an intense month, let me tell you. 22 were eligible. So we had a lot of women who were not eligible due to, a lot of women didn't meet the criteria for, their EPDS scores were not high enough. Or they were taking antidepressant and didn't want to stop. Or they worked at the same time that we were offering a class, so they weren't able to get there. And we did not, for this class, we did not offer childcare, which was also a barrier that we wanted to address in future research. So, 20 women began the yoga intervention. 2 dropped out after attending 1 class. One woman was having transportation problems. I think she was driving from Wayne and her car broke down. She wasn't able to make it. And then another woman had back surgery in the past and found that her pain had increased, and her doctor recommended she not continue with yoga. So 18 finished. And this is in 2 groups of women. We did 2 classes. One was offered in the evening at the Depression Center at U of M. We actually, because a lot of clinics are not set up to offer something like yoga as a treatment modality, we did the classes after hours in the waiting room. We had to dim the lights, we moved all the chairs, we had enough room for all of these women, and we sort of blocked off the hallway so that people couldn't come in, we were private. But we did it. The next class we ran during the daytime, and for that class we were able to get a room, I think in the East Andover Health Center that worked for it. So this was another thing that we came up against, was where do we do yoga? Where do we do yoga in a convenient and comfortable place? Of course, Barbara Bergentardi said, everyone needs to have a yoga room in their OB clinic. That's just the way that, and I agree. It would be a wonderful thing to have. Okay, so these are our ladies. Just so to note, none of these photographs, these are all clip art or from Google image searches, so none of these are actual participants. We had 22 women. Of those, 6 were minority, non-white. Very highly educated group of ladies. We have 60% with a master's degree, 32% with a bachelor's degree. We only had 3 women who did not complete a bachelor's degree. 72% were living with a partner. Not all of them were married, but they were living with a partner. And generally, they're making more than $50,000 a year. This particular question was, on the surveys, was placed in a place where people missed completing it. So we don't have as many people as we'd like. We only have 12 responses to that question. So their average mean age was 32 with a standard deviation of 4.98. I believe our youngest woman was 20 and our oldest was 41. Both first time. They were in the same class, actually. That was really nice. So most women started the class around 21 weeks, and they finished the class around 34 weeks. We did have a few deliver before the end of class, but that happens. Pretty much in that last month, all bets are off.
With the preterm milk, if that says that, website.
Yeah, sure.
Let me see if you're gonna do that.
Yeah.
Very important. So people gave birth preterm.
Yeah, 1 or 2. Yeah, there was a small sample, so we did have one mom who delivered, I believe, at 32 weeks. Her baby was okay. She spent a couple weeks in the NICU. But yeah, we did have a couple preterm births. Anybody else have any questions? So after women completed our baseline screening, which was the EPS and a general questionnaire about availability during the weeks when they could attend the class and things like that, I sat down with each of them and completed the structured clinical interview for DSM-4, which is a mental health interview that goes through all of the major mood disorders, anxiety disorders, eating disorders, psychosis, substance abuse. So we have a group of women who are pretty highly educated, mostly white, mostly in their 30s. Pretty much the demographic you'd expect to be comfortable with doing yoga. But there's a lot of psychopathology. I think in our group we only had 3 women who had no psychopathology whatsoever present in the past. Even though they were considered at risk according to the EPS, they didn't meet. It was subsyndromal or subclinical. Currently, we had most of the women had anxiety disorders, so generalized anxiety disorders, phobias, panic disorders, ketamine. No one had current substance abuse or dependence, but 45% had passed. And that's alcohol, cocaine, marijuana. We had 1 opiate. It's pretty significant. That's half our sample. And then we had 12 who met criteria for major depressive disorder in the past. We had 8 who met criteria for post-traumatic stress disorder in the past. 73% of participants had more than 1 diagnosis on the skin. A lot of women had depression and PTSD, or anxiety and the substance abuse disorder in the past. You're getting kind of a picture of who these women are? Okay. So, in the US, yoga is frequently taught in gym, right? It's a weight loss strategy, right? So you have an epidemic of classes that are leaving out mindfulness, and they're concentrating on yoga as exercise. So unlike typical prenatal hatha yoga, our M yoga really highlights the mindfulness practice by incorporating it throughout. You sort of weave mindfulness throughout the class. Target instructions, reminders, and the classes are 90 minutes. And there are a variety of yoga poses that are specifically for the pregnant body that are adapted to any stage. Marlene and Barbara were wonderful at bringing props, and so even when we were working, we did the first class in the waiting room, they were using the chairs creatively, and we had bolsters, and we had pillows, and we had straps, and to help women, because at a certain stage of pregnancy, you're not supposed to lie on your back for too long, and we knew this and were able to adapt. So sessions opened with a 10 to 15-minute check-in. So everybody in the study knew what the study was about. They knew that women in the study were struggling with mental health conditions or had in the past and didn't want to take antidepressants. So it was a sense of camaraderie. How often do you find yourself in a room with other pregnant women who are also going through what you're going through? Especially with such a powerful stigma surrounding it. In fact, the one woman who had back surgery and wasn't able to complete, we referred her to, it was an art group for pregnant women. And because she wanted to be in a space with other pregnant women who were experiencing the same thing she was. So the teachers would customize the poses. So if irritability is an issue, instructions include finding compassion towards yourself as the body experiences the hormonal changes of pregnancy. And then the classes would end with the same thing, a 15-minute restorative pose with a full body relaxation exercise. They would play soft music and read from a mindfulness text, such as Everyday Blessings, The Inner Work of Mindful Parenting, or something related to pregnancy, transition. And then they would interact informally with women before they left. Any questions? Yeah.
Did any of the women have any experience with yoga prior to this?
Yes, some of them did. In fact, some of them
Can you
were
repeat
taking-
the question, please?
Oh, yes.
Could you repeat the
Oh,
question?
sure. Sandy asked if any of the women had experience with yoga prior to completing this class. And they had. They had, I think, in that first class especially, at least 3 of them were also taking a class with Marlene on another day. So they were getting a double dose. A lot of women in our, we did not exclude for prior yoga experience. We also didn't exclude for therapy. So a lot of women who were enrolled in the yoga classes were also in psychotherapy. We didn't find any differences though. There was no significant difference between women who had participated in therapy versus those who hadn't, which is interesting. So when women are in the different poses during class, Marlene and Barbara are constantly interjecting carefully. Bring your awareness and focus inward to your breath. Bring your attention to your breath, always practicing with awareness of your growing baby. Practice the pose for your body without judgment, in a very gentle way that both Barbara and Marlene feel. So as I mentioned, they all underwent an initial psychiatric interview and then completed self-report questionnaires at baseline and then after the final yoga class. So mental health was back depression inventory and the Edinburgh Postpartum Depression Scale, mindfulness, the 5-factor mindfulness questionnaire, and then mother-baby attachment, which is the maternal-fetal attachment scale. So what we found. Maternal age was significantly positively correlated with baseline resiliency scores and maternal-fetal attachment. So the older you were, the more likely you were to be closely attached to your baby and score high in the resiliency questionnaires. The more pregnant you are, the less likely you are to feel PTSD symptoms. Marital status had an important, significant effect on social support scales. Shocking, I know. Such that women who are single, there were only 5 women, had lower satisfaction with social support and more PTSD symptoms than women living with romantic partners. Intervention effects. So this is comparing the Beck Depression Inventory, which is a 22-item scale, I believe, on depression, from the baseline, which was before the first class, to post-intervention, and it was significantly different. This average scale started at an average of 13, 14, and went down to 9.5. And the EPDS was from 12, which is significant. An average of 12 is significant, to 7, which is just below what would be considered a risk. And that was even more significant than EPI scores.
So what would the score be if you weren't at risk of being pregnant?
8 or lower. And for the back depression inventory, I believe it was 10. Yeah. So it's, yeah. Mindfulness skills. The total score, this was a survey that had several subscales to describe the different ways of being mindful. The total score improved significantly over the course of the intervention. The result was mainly driven by significant results on just one subscale, the non-judgment subscale, and then a trend level change in the observed subscale. I mean, it seems to make sense that if you're approaching activities and behaviors and thoughts and emotions with less judgment, you're going to be less depressed. If you're closer to observing, the observed subscale is about when you're breathing, I can feel my chest expand and fill up with air. I can feel my chest contract. So you're actually in touch with what's going on right now in the moment. And a trend level basically means we had such a small sample that maybe perhaps we've had more people, it would have been significant. So we hope it is. Maternal fetal attachment was the big winner here. And this was compared to, you would think that women, as you progress through your pregnancy, are going to become more attached to the baby. That sometimes happens, but it doesn't always happen. And this was compared, this was significantly different than just what we would expect to happen during pregnancy. So the total score was, went from 83 to 95, significant. But women who were more comfortable taking the role of the mother, they were able to differentiate themselves from the baby. And those were questions like, the baby is kicking me because it knows that it bothers me. And women who said, no, I know that this is the baby and it's a different being than I am, would score higher on that particular scale. Interaction with fetus would be like, I like poking my belly and seeing the baby response. Giving of self. So I do things specifically for my baby that I wouldn't necessarily do otherwise. So, and these were correlated. The pre and post group measures were correlated. Most significantly with the pre-BDI and the post-BDI. So depression before the intervention significantly predicted depression after the intervention. And maternal fetal attachment too. This is my favorite part, was doing the post-class feedback surveys. We actually met with each group of women with their babies postpartum. And Marlene and Barbara met with them, and they talked about their experiences and what yoga was like for them. And we heard some great stories. So these women are saying, yoga helped me to cope with a high-risk pregnancy, and my son is the most calm and gentlest of souls. The stress reduction really helps the baby too. They love the social support. A lot of these women made friends with other women. In one of the groups, I think that one woman invited all of the women in her class to her baby shower. These are women she just met, a few weeks beforehand. So hearing from the other moms made me feel much less alone. I really benefited emotionally from sharing with the other participants, and benefited physically from breathing and relaxation exercises. They loved the classes, they loved the teachers. The breathing and mindfulness exercises allowed me to have the delivery that I wanted. It was perfect. I loved all of it. The readings were excellent, and the instructors have a true passion for helping pregnant women. Barbara and Marlene are fabulous. They really are. So our findings suggest that the M-yoga intervention is acceptable and effective for women with mild to moderate depression. We attempted in our analyses to break them down into groups of mild, moderate, and severe depression. Our sample size wasn't big enough. It really wasn't effective. I think we had maybe 3 people in the severely depressed category, so we really couldn't do a lot of analyses there. For severely depressed women, we were speculating maybe M-yoga is going to be beneficial if you add it to other treatment modalities. So maybe a mindfulness practice at home with exercise, in addition to therapy, in addition to a weekly class. Or for women who, I think we had one, no we didn't, but women, if they wanted to start taking an antidepressant before the end of the study, they were welcome to. But you could also argue that if you're severely depressed and you want to stay on a low dose of your antidepressant, thinking yoga would help you manage your symptoms enough to not take more antidepressant. And obviously the strongest impact is on maternal fetal attachment. It improves significantly across the board, totally independent of symptoms level and the presence of current symptomatology. So as I mentioned, they became more comfortable assuming the role of a mother, enjoyed interaction with the baby, easily separated themselves from the baby, and were more likely to engage in healthy behaviors because of the pregnancy.
So do you think that the yoga itself helped the attachment?
We can't. That's what we're theorizing. Partly because a lot of obviously this is just one study, we can't necessarily generalize, but because there was so much in the classes that was about connecting with your baby, it was a reminder. I mean, I think there's things like women said, I like the way they reminded you that there was a baby beating underneath your heart was your baby. And that was something that they kept reminding you about all the time. It's something that you think about at other times. So yes, that is one of our theories, is that the mindfulness-based part of the yoga increased attachment. Maybe women, it's interesting because when you think about attachment during pregnancy, there are a lot of myths that come up. Is that women easily attach their babies, and that their stuff just happens naturally. It doesn't always happen that way. Sometimes women need a little bit of help. Like one of the subscales of the maternal fetal attachment scale survey was not attributing characteristics to the baby. So sometimes I've heard women say in research studies or in clinical practice that, well, my baby's just crying because they know that it bothers me. They're waking me up at night because they just want to mess with me. And these are things that sometimes happen. And if perhaps the mindfulness aspect of yoga classes introduce the concept that isn't necessarily the case. And it's okay to say, I'm connected with my baby and I'm feeling close to my baby and I are we're a team to do this together. Does that answer your question? Yeah.
I'm wondering if, has there been a study that looked at the progression of maternal fetal attachment in depressed women who were not, did not have either this kind of,
yes.
and so these are really different scores?
Yeah.
Okay.
Yeah, because that's one of the things that we wondered too. Is maternal fetal attachment more difficult for women who are depressed? It is. It is. And without an intervention, I mean, I can't quote the study right off the top of my head, but yes, it is different.
The nice thing too is at least you have a base with a pilot and then adding on another group.
Right.
I had a couple of questions.
Sure.
Do you want, is it okay to ask
Yeah.
now? One was, did they have time at the beginning? I wasn't sure on the mind graph. Did they have time before where they almost had like a support group discussion, debriefing, or did people come and the session, like how much time did they have before your yoga started, or was there any organized debriefing of those things?
Please repeat the question.
Sure. So just asking if women had a organized social support network group before the class started.
Yeah,
is that
once
right?
they arrived for the class.
Yeah.
Was there that, or did they get together and then you said there was 15, 20 minutes of kind of like centering themselves, but structured through the class?
It was, when women were arriving, the 10 to 15 minutes in the beginning was that structured social support.
Okay.
They literally would sit in a circle and everybody would talk about their highs and lows for the week.
Okay.
And that's what they would do at the end too.
So similar to almost like a mindfulness-based stress reduction program where you kind of debrief how did last week's whatever you're continuing to practice.
Yeah.
The other question was, in your follow-up study or in the study, you didn't, use any physiologic measures, all paper pencil?
Yeah, we would love to do them in future studies.
Repeat the question.
So
please.
the question was, did we use any physiological measures? And we did not.
Yeah, to take like a biobehavioral approach. Sure.
We would,
Like blood pressure and pulse and those
Yeah.
things, you mean?
Yeah, or salivary cortisol, alpha amylase, like looking at an indirect marker for catecholamines for stress response.
so we're looking at catecholamines, stress response, salivary cortisol. We did look at salivary cortisol.
In this study?
We did. We did not find any changes that were significant. There may have been problems with the way that instructions on how they were collected. There's all kinds of confounding variables.
So when were they collected?
Prior to the class beginning, they brought, a lot of women brought their, they were collected at, I believe, 3 times, no, it was 4. Right before they woke up, just as they woke up, 45 minutes after waking up, in the middle of the day, and right before they went to bed.
Okay. And was the class at the same time each week?
Yeah. I believe they took saliva samples for 3 days in a row prior to the class starting and then after the class was over. But we did have some trouble getting, which happens in a pilot.
Yeah.
You have some trouble with, I didn't know quite how to collect this, or it didn't go in the refrigerator, or it didn't get turned in before the first class, it got turned in the second week because they forgot to bring the materials, or when we got recruited late. So it would be very interesting to see in the future in other studies physiological responses.
So you guys did cortisol and alpha amylase?
No.
No. For your follow-up, what markers are you using?
I think I have to check. I believe we were looking at body composition, like weight gain, and heart rate, and blood pressure. I believe that's what we were going for. We would love to do something like an fMRI beforehand. I think the pregnancy and fMRI is a little bit murky there. Yeah, I hear they're doing it at Wayne, but not here. So we would be open to exploring all kinds of possibilities in terms of physiological measurements. But
I think another contributor of the yoga was the fact that women who are calmer are more prone to connect to their child than a depressed woman. And also when you do yoga during the pregnancy, the child is much calmer, so it's bound not to cause so much problems to the mom.
very true. Yes, I agree with all of that. Yeah.
Hoping to avoid any research design stuff because I know from studying in the past that you can get really crazy about it. But I'm very curious just about your opinion as to whether yoga itself or more the fact that they were joining as a group. I was thinking that it had a huge influence on the outcome. And if so, how would you be able to separate that in their future research? And has anybody looked to see whether the same type of research is being done globally?
Yes. So the question was, how do you separate, and from a research design standpoint, how do you pull apart the effects of social support from yoga, mindfulness, and how would you measure for that? And are there research projects that have looked at that? Is that right?
For future research.
For future research.
Yeah, anyone looked to see whether they have done this kind of research anywhere else? You seem to be saying that this is your own unique thing, and I thought, man, there's got to be other people looking at this because it's such a need.
Oh, yeah, there are other people looking at this, but not with women who are actively depressed. That's the trick. That's the difference between this particular study and other projects that have been out there. There are other projects that have been done, like comparing a walking group to doing yoga at home. Like women were given a DVD and they do it at home, or instructions, and then, or women come and they walk, they participate in a 30-minute or 90-minute walking group with other pregnant women. So yes, they are looking at these kinds of things, and one of the things that we looked at, the results from, we did have a follow-up study. It was very small. The results are not ready to be published. But we did, one of the things we were thinking about was, why don't we film our yoga instructors doing class for an hour with, like, you know, pregnant women, and record it, and then give it to women who are randomized to a control group who does it from home. Yeah.
So interactive versus just, participating
Yes.
in yoga.
You have a lot larger things.
Precisely, yes, and we found, I mean, preliminary results from that project was that the control group almost did better than the intervention. Because they could do it from home, and they could do it multiple times a week. And they also received, I called them every week, so we would, they received check-in phone calls. So for women in that study, it was very small, but they, like, if your car broke down, it didn't matter.
Yeah.
One woman described, I'm doing the yoga every day, and my 2-year-old's doing it with me. You know, because for that study we expanded the eligibility criteria a little bit. So yes, it was something we really love to look at, because if we can find that yoga DVD and check-in phone calls works, how incredible is that? Like, we can just copy a DVD and give it out to women at prenatal appointments. That's really, really incredible. So, you know, I mean, obviously, like, the in-person aspect does bring something, and, you know, that was a very small study. We can't really say what the results were necessarily. We had done a larger study. But yeah, we are looking at it. Does that answer your question?
Sure.
Okay. Okay. So one of our theories was that it's possible that strengthening mindfulness skills and increasing resilience to stress, enhancing attachment between mother and baby, maybe helped women avoid worsening depression. So they had minimal depression symptoms at baseline. They didn't score much higher on their depression inventories. Perhaps a sort of mediated depressive episode. It's a theory. Limitations. Small sample size. It was pretty good for the 2 groups that we ran, but I would have loved to run 2 more and get 40 women instead of 20. We had a really homogeneous sample population. Highly educated white women who worked harder. And we never controlled her, so how do we know? But it does provide a solid foundation for future research. And when we do pilots, you learn how to do the next project. So obviously more research is needed to explore these effects on pregnant women who are unpartnered, under age 25, and from diverse ethnic backgrounds and with fewer resources. So this is the current project that we are still analyzing. So we had the intervention. I think we had 6 women in each group, 6 receiving the yoga intervention, and then 6 receiving the home practice, free mindfulness yoga DVD, and then weekly check-in phone calls. And we specifically targeted recruitment, like we expanded our recruitment to women 15 and older. And we offered this class at Hygeia Center for Healing Arts in town. And then obviously DVDs were home. And we provided yoga mats and bolsters, I believe, to women who didn't have them. So we were able in the home practice group to target women who had never done yoga before. And the woman I was describing earlier who was doing yoga at home with her 3-year-old, who was doing all the poses with her, she'd never tried yoga before. She was 24, African American, second child, history of severe depression. And she said, I'd never done this before, and now I do it all the time. It's becoming, some of these are really helping with my low back pain and helping me manage my mood, which is awesome to hear. And then women who had like transportation problems, they were like, it's not a problem because I don't need to get to Ann Arbor to do yoga. I can do it right here at home. And then the women in the group really loved bonding with one another and continued talking outside of class and went to each other's baby showers, and it was really beautiful. So one of our participants who was unable to attend due to transportation problems, she really liked going to the one class that she did attend. And she was really disappointed that she wasn't able to come back. Even though she'd never tried yoga before, she was one of 2 women of color in that group. Youngest one in the group, only single mother. And she had living in poverty, very little social support. She had some significant psychosocial stressors impacting her daily life. And her experience helped us to rethink how we want to offer the next round. We really would love to partner with the Corner Health Center in Ypsilanti. They have a great space in their basement that we could offer mindfulness yoga, and women could come to their OB appointments and then go to yoga class, and that would be wonderful. And they do with other teen moms. And of course, Barbara's dream of having a room devoted to yoga and mindfulness and meditation in every OB clinic would be really wonderful. And it's about attending to in a familiar setting. The reason why we offered the first 2 classes at the Depression Center is because a lot of women had already been there. And they were receiving therapy there, they knew their doctors there, or they were going to their OB care at East Hanover Health Center, which is right next door. So we're like, oh, we know exactly where that is. That was a very, very helpful aspect. Then we're going back to Ashley. Ashley has been scheduling therapy appointments weekly. She no-shows and cancels about once a month, but seems to be making some progress. After establishing rapport, her therapist has made several accommodations to address the variety of barriers to getting care, such as offering childcare for her son and daughter during sessions in an adjacent room, conducting brief sessions by phone when she's unable to come to the clinic, and helping her enroll in the maternal infant health program, which I'm sure you're all familiar with. No. It's a wonderful program that is specifically for women who are in poverty or struggling with social support, where they are offered nutritional guidance right in their OB appointments, or therapy right there. So you go to your doctor and you get therapy, you get nutritional guidance, you get CAD vouchers, you get baby supplies, all kinds of amazing things. At 26 weeks gestation, Ashley is still reluctant to try medication. So her therapist was helping her integrate traditional psychotherapy with alternative approaches, such as meditation and exercise. During therapy sessions, Ashley is learning ways to manage her depression and PTSD symptoms, improve her social functioning, adjust to role transitions, and work through her traumatic experiences by way of an interpersonal and cognitive behavioral therapy approach. Finally, Ashley has enrolled in a prenatal mindfulness yoga class, allowing her to interact with other pregnant women at risk for symptom pathology and learn new ways to cope. The yoga class, taught by a therapist connected with the perinatal team, facilitates social support by pairing each pregnant woman with a fellow class member who is further along in her pregnancy and designed to continue into the postpartum period, encouraging women to bring their babies to class. This is also something we would love to offer in the future. Marlene does this in her classes at Inward Bound, where she literally will pair pregnant women together and then they keep in touch and people tell labor stories. It's really wonderful.
It's a great mentoring of each other.
Yes.
And building a sense of community.
It's a great mentoring of each other, building a sense of security. So Ashley's baby was born small but healthy at 38 weeks. During labor, she used many of the yoga poses learned in class to manage pain. She ultimately elected to have an epidural after 30 hours of labor, which I think is completely fair. Her baby was observed in the NICU for 2 days, just to make sure he was eating okay and getting enough weight, and breastfeeding was doing all right. She started breastfeeding while she was still in the hospital and plans to continue. Her therapist spoke with the hospital's social worker on call during Ashley's stay to assist with coordinating postpartum care and plans to check in by phone later in the week. Ashley is looking forward to her first postpartum yoga class, especially after one of her classmates came to visit her in the maternity ward. Ashley's therapist will continue to stay in touch with her by phone until she is ready to schedule another appointment or assist with referrals to other community resources. Here's just more information about the perinatal team and phone numbers and stuff. It's all in PowerPoint. And the Corner Health Center. And in case you're interested in mindfulness, iTunes has a lot of free podcasts. Some great ones are my meditation podcast. Meditation Oasis literally has a Connecting with Your Baby podcast. Download for free. Use them in MP3s, you can burn them on the discs, you can get notifications, refer them. And then freemindfulness.org also has a lot of great resources. And then one of the books I loved reading when I was doing some of the background research for this project was Mindful Motherhood by Gisela Biden. She's one of the researchers who's looked at mindfulness and yoga during pregnancy. It's a fabulous book. Questions? Yeah.
I was wondering if I guess I wasn't familiar if there were any antidepressants that would be safe during pregnancy. Are there?
Yes. Well, again, the question is, are there any antidepressants that are safe during pregnancy? It's interesting because I'm helping Maria write a review right now on safety of antidepressants during pregnancy, so I've just done a lot of research on this. There's no definitive evidence that any antidepressant causes no problems. However, OB-GYNs and psychiatrists are weighing the risks of untreated depression with antidepressants. Because I think I got a slide on untreated depression. The trouble is that every pregnancy has a 3% risk of malformations. That goes with anybody, age, health, whatever. When you're taking an antidepressant, it does add to that risk, but how much does it add, does untreated depression add risk to your pregnancy?
That leads to my second question.
Right.
Because I wondered what kind of risk there is to the baby with untreated depression.
Low birth weight, high blood pressure for mom, more complications during pregnancy, preeclampsia, smaller head circumference, babies have longer stays in the NICU, there's all kinds of stuff.
The
Yeah.
other thing too, I think we're starting to get more and more research looking at being really depressed or extremely stressed
Yes.
during your pregnancy, and almost from an epigenetic standpoint of what could be the long-term effects on a baby. And the nice thing I think with your study and laying the groundwork for more
Yeah.
and increasing the numbers and the variety of patients to see how it can extend out is that how fabulous to have a non-pharmacologic treatment
Right.
that might give as good or potentially better without the negative consequences of some of the
Right.
pharmacologic medications. But obviously for patients who don't want to participate, or there is a level of risk benefit and you're willing to, to have a medication, and
Yeah.
even after we don't know. I mean, even look at the recent research that came out with Tylenol and
Yeah.
pregnancy. So something that we've had an extremely long history of feeling is safe to take.
Yeah.
So I think that most women, the nice thing about pregnancy is such a huge transitional, transformational time,
Mhm.
are open to so many
Right.
things and really looking for what's best for themselves and their baby.
Right.
So more options is always a positive
Right.
thing. But-
So, basically saying that we're looking at what are the long-term health risks of babies who are born to women who are struggling with depression or high stress during pregnancy, and that it's good to have alternatives no matter what they are, especially for mind-body stuff like this. I will say that one of the things that I've learned that's been very clear in doing the research for this review paper on the safety of antidepressants during pregnancy, this is a hot topic. People have very strong opinions about it on both sides. And there have been 10 reviews or meta-analyses in the last 3 years, like of hundreds of studies, looking at specific outcomes. Why do we need 10 in the past 3 years? And then in the last, I think I've read probably abstracts for about 100 different articles in the last 3 or 4 years on this very important topic. And I mean, they're finding, obviously, when GlaxoSmithKline pulled or put the warnings out about Paxil back in 2005, they found that in their studies, which were not like randomized controls or anything like that, there were more heart defects. But Zoloft, Prozac, Wellbutrin, Celexa continue to be prescribed. There's a lot of research that's been done, but it's observation research. As I was saying earlier, we can't do a randomized control trial. You can't have women randomly controlled, randomly assigned to different groups where, okay, you don't get your depression treated at all, you have yoga, you have Paxil. There just isn't going to work. Yeah. So, and one of the things that the American College of Obstetrics and Gynecologists talk about is how it's important is to make care individualized to each woman and to have a real conversation. Because there are a lot of women who, one of the other projects that's happening in the Department of Psychiatry was about barriers to women seeking care for mental health conditions during pregnancy. And one of the things that women were saying in that study, they were worried they were going to be forced to take antidepressants when they talked about depression in an OB appointment. And if you think about it, it makes sense. If you have high blood pressure, they're going to want you to take a blood pressure medication. If you have gestational diabetes, if you aren't able to diet control it, they're going to put you on insulin. So why wouldn't they make, right, nobody's going to force anybody to do anything, but when you talk about the health of your baby, most women are going to, okay, this is what I'm going to do. So I find that really interesting.
I think also the stigma attached to it,
stigma.
and also, quite frankly, many people are not asked many significant questions.
Yes.
Because of the ramifications of the answer, which can entail time, effort, and
right.
Another example would be, the lack of asking people with domestic violence,
right,
or sexual abuse,
right,
which obviously impacts someone's emotions and feelings during that time. So I think that the one thing that I really like, and it stimulates me to think as a midwife about this, is that especially in a centering model of prenatal care where you have the capacity for more time to talk with people,
yes,
and then a group of individuals, I feel that we really, really need stress reduction techniques added into it. Especially when we look at the national rates of infant mortality, Michigan's, and then specific to Detroit, we have the worst infant mortality in the country. Yeah. And we keep doing the same things over and over and over again and hoping for different results.
Which is the definition of insanity.
Yes.
Right? Yeah.
So I really feel that what we need to do is move to a new model of care like this, coupling with group and then having a captive audience with people that can learn techniques to help them alter their life and have a physiologic impact, take care of their mind and their body and their spirit. So I think you guys are doing fantastic work and meaningful.
Thank you. Thank you. So talking about how a lot of questions are not asked in an OB setting, and so this individualized care idea is something that isn't being addressed, and that you were mentioning that Detroit's infant mortality is the worst in the country, and we keep doing the same things over and over, and to have more options is very important. And to ask these questions, and I think too one of the things that comes up is that clinicians don't know how to prescribe, how to treat depression in pregnancy. It's not necessarily seen as a significant health condition. If it's 15% of pregnant women, and that's the reported, right? You know it's going to be higher than that at any stage in pregnancy, and then there are women who have subclinical symptoms. And doctors, I think it goes back to when you're working, people tend to see pregnant women as very delicate, which they are, very delicate and uncertain, and I don't want to make a mistake with a pregnant woman because the ramifications are going to be so much bigger. The other side of that is if you're going to make a mistake and not treat her effectively because you're worried about making a mistake, then you have the same problem. So I think education of doctors, and I think of education of any health practitioners, and then the reduction of stigma around it, because I had a friend who wouldn't chew sugarless gum when she was pregnant. So, right? Okay, so we have, if a woman is in a coffee shop, she's at Starbucks and she's getting a coffee and she's 6 months pregnant, she's going to get looks, she's going to get, everybody's got an opinion when you're pregnant. So if you're taking an antidepressant, you're going to get defended all the time, you know? Or you're not, your femininity is brought, your motherhood or your maternal instincts, all of these things are brought to, which is not fair, but it exists. And if you have to, maybe for people in your family or people, your friends, maybe they made different choices than you did, it's harder for people to understand.
And you've been pulling this out of, this is specific for psychiatric, you know, patients at risk for psychiatric, but when you look at the risks involved with chronic stress.
Yes.
So individuals who are living in chronic stress situations, which many inner city individuals are.
Yeah.
Teaching people different ways of handling that stress to evoke the relaxation response is really powerful and life-altering, and because people are so open to change and the best potential outcome for themselves, you could potentially, really change one person's life, but you really have a ripple effect that is really significant.
Absolutely, I totally agree. So I'm just phrasing for the camera. So we were talking about how powerful stress reduction techniques like deep breathing can have help in women who are not just psychiatrically at risk, but have a lot of stress going on in their daily lives, a lot of psychosocial stressors. Very interesting to bring that up because in Maria and Kate's one of their other projects is Mom Power, which is a parenting, self-care, psychoeducational, attachment-based parenting group. So it's a group where they're focusing on low-income, at-risk mothers who are struggling with depression, anxiety, low social support, who have children, and we teach them how to breathe. It's one of the things we do. The theory being that you put the oxygen mask on yourself before you put it on your child. So taking care of yourself is very, very important, and then you can take care of your child. And we give them a CD of basic meditation stuff, of how to breathe and how to cope with panic attacks and container visualization, safe place visualization, the concept of a safe place you can go to in your head all the time. I was honored enough to be able to co-facilitate 3 groups of Mom Power specifically for women who are struggling with drug and alcohol addiction during pregnancy and early postpartum period. And I mean, it's just an incredibly powerful thing to go into a group of women who maybe had never had healthy peer relationships modeled for them or had ever learned about breathing and its effect. One of the practice exercises we gave them was 10 slow, deep breaths. Let's do that right in class now. It'll take a minute, and let's evaluate how you feel. So it can be extremely powerful. And just that small introduction, and then it does have a ripple effect. Because one of the things we hear is that I'll go on study visits for other projects, and I'll hear about Mom Power. Oh, you can. My sister-in-law did Mom Power. I really want to do that. She taught me some of the things that we learned. And so how do we, women who, one of the great things about the social support aspect of my yoga project, and from Mount Power too, is that women go home and tell their sister-in-laws and their sisters and their partners and their cousins and aunts and mothers about it. And it's getting disseminated without us having to do anything.
I've got a yoga question. I just then found out a few months ago that there's different kinds of yoga.
Yes.
And you said that not use hatha yoga. So what kind of, if I wanted to look for a mindfulness yoga group that so I could control my stress in my life, what kind of group would I look for?
I wish Barbara Marlene were here because they can answer that question way better than me. So the question was about different kinds of yoga. If you were looking to take a mindfulness yoga class, what kind of yoga would you take? I would say that Hatha yoga is what's offered in gyms, or what's a traditional prenatal yoga class. Okay, it's just physical poses, there's breathing involved, there's a little bit of mindfulness, but it's not as emphasized as in this particular intervention. Iyengar yoga is about holding poses for long periods of time and being in that moment. There's devotional yoga, where you can go and actually devote this class to. I have a good friend who is pregnant with her second child after a loss. She lost a baby at 32 weeks, and she's pregnant again. And she's amazing. She's incredible. She's taking a class that's devotional prenatal yoga, and she devotes those classes to her baby, her first child. And that's a very powerful thing for her. So I think it's about, like, you can call yoga studios and ask them what kinds of, basically, if you call a yoga studio and ask them what kinds of classes they offer, they'll be able to give you information about that.
Do you have any negative comments about the mindfulness because that obviously brings you inward,
Yeah.
focused, and especially if some of the inward focusing is scary.
Yes.
That potentially, because I've often thought that with individuals that are extremely, like, I've loved mindfulness-based stress reduction for
Yes.
myself, but I have a different life than some who have many, many, many challenges. So then, when I think of a jumping of a theoretical to a clinical setting, I've often thought, well, kind of like your question, like, would it be better to do loving kindness meditation with them rather than mindfulness-based? Did you have any negative comments about focusing so much on the here and now, if the here and now can be potentially very breaking?
Okay. So the question was, did we have any negative comments about mindfulness? Because mindfulness doesn't necessarily mean relaxation. That's something I think that gets mixed up. If people think, oh, it's mindfulness meditation, I'm going to feel better, that isn't necessarily the case. We did have one woman who, and I'm remembering, she had some difficulty doing some of the poses and was in the home practice group and really wanted to be in the class. This is in the follow-up we did. And I remember she said she was just getting very frustrated and trying to sit with that frustration by herself in her house, not knowing what to do. And it helped that we had one of the yoga instructors contact her and they talked through some issues and then things got better for her in that particular instance. But that was the only one that I've heard of. Question though. I'd have to look at some of the transcripts from the focus group follow-up after, but that was the only one I can remember. And I remember once we reached out to her and were able to kind of let her know this is normal, this happens, then it was easier for her to handle it. Does that help? Mm-hmm. Okay. So we've got, what, 15 minutes? Any more questions? Okay.
Yeah,